or admitting a person who needs a secure facility, knowing we don't have access to a secure facility. Our nurses will require indemnification in situations such as this. Again, under Croke Park, we are required to cooperate with the provision of authorised officers, which is again provided for under the 2001 Act. Authorised officers are senior health personnel who are trained to a point where they can make an objective evaluation that it is appropriate to make application for a person to be admitted for mental health care in an approved centre. In circumstances where relatives, even if the believed person requires treatment, are unwilling to make the application. In countries where this service is widely available, applications from authorised officers account for nearly 90% of all compulsory admissions. In Ireland, it is currently below 10%. Initially, 160 personnel were trained nationwide. Following their initial training, nearly half of those trained withdrew from the provision of the service. Today, about 50 of those staff remain in the service, with approximately half providing services. Now, the HSE has sought our cooperation in developing, promoting and enhancing this service. We are well disposed to reaching agreement with the employers on this. However, it is essential that we establish the reasons why so many staff who were trained then withdrew, what grades were involved, and what are the issues which need to be addressed in order to ensure this service can be provided to our citizens. While it can be postulated that some staff would be fearful of cross-examination by barristers at tribunals, others may be fearful of the actual challenge of assessing the mental health of individuals, and others are offended by the small levels of recompense for this onerous duty. It is essential that we establish in an open and transparent manner those factors which militate against staff taking up the role. It may well be a factor that some non-nursing staff will feel they need a basic grounding in psychiatry in order that they would be confident about identifying when it is appropriate to make application for an assessment of a person's need for compulsory mental health care. We'll see in the coming weeks. The Chairman referred yesterday to the visit of the European Committee for Prevention of Torture, and it recently published its report on its examination of Irish prisons and a number of mental health services. I am delighted to note the many positive comments of the inspectors in relation to the quality of caring they identified in their inspections of St Brendan's, St Eda's and St Michael Hospital. Their observations on staffing and violence are consistent with our own report on mental health service and crisis published last September. While the PNA was pilloried for highlighting violence as an issue in our services, no such attack was made on the European Committee. When we published our report, the cynical response of the HSE, and we know this for a fact, was to phone advocates of the mentally ill, insisting that they should publicly condemn our observations. And recently, the former Inspector of Mental Hospitals, Dr. Dermot Walsh, a good friend of the PNA, came out of retirement to say, inter alia, that staff reps highlighting violence in our services are contributing to the stigmatising of the mentally ill. He's right. He is right. I have to accept that when I speak, that it cannot be denied that when we comment on violence within the mentally ill numbers of the population, it does have a stigmatising impact. The question then is, should we remain silent? Should we ignore our everyday experience? Should we pretend it doesn't happen? And my answer is no. We must call on Dermot Walsh and those cynical apologists within the HSE who seek to undermine and deny the truth to tell the full story. Tell the public that cutbacks stigmatise the mentally ill. Failure to invest in comprehensive mental health services and primary care stigmatises those experiencing psychological distress. Tell the public that only a small minority of our clients are violent, but they are violent. And their violence increases when they are not provided with enough staff, when they are denied activation, when their space is encroached upon by other sick people who inadvertently wander into their space, who themselves are not being provided with a comprehensive service, when patient types or groups are inappropriately mixed, when numbers are inappropriate to the available space, when the facilities are inappropriate and staff are having to make do. Tell the public that the HSE are cynically cutting mental health funding, not investing in recommended services, paying lip service to the available knowledge and research. In the bad old days of the mental hospitals, we invested 13.8% of the health budget on mental health. We have now closed most of those hospitals. Services are now provided in more than 800 small units and homes around the country. Services are less visible, and with that loss of visibility, we have seen the investment in mental health services reduce further, even further from 6.8% 5 years ago to 5.2% today. I ask the question, is there any point beyond which the HSE will not go? For the last 20 years, I have highlighted the issue of assaults on nurses. I will continue to do so. I would love to be in a position to move away from this issue, but for as long as our services are denied funding, for as long as our patients are denied access to proper care, for as long as our HSE managers continue to take risks with the health of our members and indeed our patients, I will continue to highlight the problem, not to stigmatise those experiencing mental illness, but in the hope that at some time in the future, the worst of these awful cuts can be ameliorated and our services made safe. It is a fact that violence is a feature of many parts of the health sector: A&E, psychiatry, ID and dementia services. Cutbacks result in cuts in staffing and cuts in therapies, with resultant increases in violence. Our nurses and other staff pay the cost of those cutbacks through their injuries. In recent months, I met a number of injured nurses, including one woman who will probably never work again. This young woman worked in an ID service in the west of Ireland. One very challenging client needed the dedicated support and diversionary therapy provided by two nurses who were assigned to his care. Because of cutbacks, those two staff were withdrawn. He then seriously assaulted this nurse, whose injuries are impacting on all parts of her life. Undoubtedly now, litigation will follow, compensation will be paid, but the reality is that the client has suffered because of the reduction in services available to him, the nurse has suffered because of her appalling injuries, and the HSE has lost the services of a nurse and will incur the cost of a 5-6 pension and the increased insurance costs associated with all these assaults. One can only postulate that it is surely better for all concerned to invest in safe care rather than incur the costs associated with inappropriate cutbacks. Colleagues, the decision of the new government to appoint a Minister for Primary Care is very welcome. It tells us that the government is serious about primary care. We have now sought a meeting with Minister Roisin Shortall, at which we will point out that if the government is serious about primary care, they must tell the HSE primary care managers to rid themselves of their bias against mental health in primary care, or replacement managers with a broad-based commitment to comprehensive mental health services. Comprehensive primary care means that all the health needs of the population can be addressed in the one-stop shop that is meant to be primary care. Mental health professionals capable of taking referrals from the GP, assessing their mental health needs and providing appropriate interventions are referred to other members of the team or to secondary care must be available on all primary care teams. The current con job on the population must stop. Placing secondary care mental health teams in the same building as primary care teams is not providing primary care mental health services. We do have primary care mental health services in Cashel, in Ballymun, in West Cork and parts of Kerry, and they are hugely successful. I ask, why should citizens be asked to become patients of the mental health services when they should be able to access treatment easily, early, without stigmatisation from a primary care mental health nurse? How many persons referred to a psychiatric clinic have deferred their appointment for fear of being labelled? How many have deteriorated? How many have died by suicide when help should be so easily available? Our citizens should be able to access treatment more easily. Why should they have to become the property of a psychiatrist when all they need is to access CBT counselling or some other psychological therapy rather than secondary care in an outpatient clinic or acute unit? We have known for decades that there is excessive prescribing of antidepressants or anxiolytics. Should our GPs not have the support of a specialist mental health nurse before deciding on the appropriate care strategy? Our young people who self-harm in such large numbers must be able to access mental health care as easily as they can contraception. Our small number of specialist mental health primary care nurses have proven their worth. They have produced research to demonstrate the success of their work. They have demonstrated an ability to respond to people in need of psychological intervention, to add quality to primary care services, to reduce the need for secondary care. Why, oh why, do HSE managers continue to ignore these facts? Why do they pretend to provide mental health care at primary care level? We now have a dedicated Minister for Primary Care. We have a government which has talked the talk. We will now see if they're going to walk the walk. We say to our new Minister, our people are entitled to a comprehensive primary care service with dedicated specialist nurses who will help them to address their mental health challenges. Families with ID children need access to specialist ID nurses in primary care. We look forward to seeing that reality coming true. You've heard a lot over the last couple of days, colleagues, about the study trip to Holland, and I want to refer to it as well, and perhaps to give you a different side of it. It was a valuable visit which threw up many interesting experiences. Meeting nurses who were happy with their lot, who felt their work was respected and appreciated, who saw their managers as people who would resolve any work-related problems that might arise, who saw opportunities to develop, to specialise, to advance their practice as something that was readily available and accessible. They have over 300 ANPs in mental health in Holland. If we had a proportionate number in Ireland, we would have over 100. Instead, we have a tiny few. Just as an aside, I discovered this week 3 ANPs in Mayo have qualified, are registered with Bord Tronish, 1 in oncology and 2 in liaison mental health. The one in oncology in the General Hospital has been appointed and has been paid as an ANP, and the 2 from mental health have been told that there's no money for them. So the prejudice and the bias against mental health is alive and well, but we'll fight it. The population of 16 million people in Holland live in a country no bigger than Munster. Many don't own a car. Public transport is extensive, easily available, and appears inexpensive. While public servants earn less than here, their cost of living are a lot less than what we have here. The comparative earnings of nurses, when compared to consultants and others, are greater than here. In other words, we're closer on pay than we are in this country. Interestingly, premium pay was mentioned by the Minister this week as in the private sector. Premium pay in Holland is paid differently than paid here, but over the week it is more valuable because of the value of Saturday pay. So they have a very good deal on premium pay, in their premium pay. They have never had a public health system. It has always been insurance-based. Every person lives within 3 kilometres of a GP. It is a routine experience for those who visit their GP with a mental illness to be referred to a primary care mental health nurse. For those who require secondary care, that service is provided in small dedicated units. While we have learned a lot about the Dutch system, many questions remain, and the greatest challenge being how that system could be transposed into an Irish context. We have sought an opportunity to engage and contribute to the Department of Health's work in this area. I would like to think that we will approach this from the perspective of taking what's best and leaving the rest. I want to move on to one of the demands required of public servants under the Croke Park deal, the commitment to the introduction of performance management. On April 5th, the unions were given a briefing on management's proposals. In the hands of good managers, performance management is an appropriate tool which complements good practice. In the hands of a bad manager, and by God we have a few, this could result in the empowering of bullies. HSE management have traditionally safeguarded and supported and indeed promoted bullies. One former senior manager described one of his most difficult lieutenants when he said to me, "The problem with Martin, God rest him, is that he gets things done, but his body's in his wake." And that seems to be acceptable. I have met staff who were left suicidal by pathological bullies. I have met staff who left employment in one area, sometimes in promoted posts, and re-enter the service in a different area at a junior, temporary or locum level.